This short little presentation is what we were giving to our elected officials last winter when we were trying to get co-sponsors and a sponsor for our House bill. Now have a Senate bill and a House bill. So it's pretty short and sweet and designed to be done in like 15 minutes. And at the end, what I'm hoping is, and not necessarily right now, but for you guys, if you guys come up with ideas and recommendations, we really want to look at what we can do emergently, because of the situation, we're currently in. So the Washington Health Trust, I think I went past the first page, right? I'll try to. Okay, what? All right. Here's the Washington Health Trust as it's been presented in 2025. And what it is an act that creates a healthcare financing plan leading to the development of a just healthcare for all coordinated system for all Washington residents. It ensures that all Washington residents can enroll in a nonprofit healthcare coverage plan that provides an essential set of health benefits, including medical, dental, vision, and prescription drug benefits without excessive copays or deductibles. It is estimated from the last funding studies to save our state $5 to $9 billion a year and is comprehensive and affordable for both our businesses, our state, and our individual residents. Those numbers may not be correct any longer because it is dependent on a lot of federal money, which might be going away. It's written by the community. It incorporated the work of the Universal Healthcare Commission that we have here in Washington. We incorporated feedback from over 24, actually it was 30 town halls during our 2024 town hall road trip. We incorporated feedback mostly from the business community and our rural communities, trying to understand their issues. We also took suggestions from the FAT Legal Advocacy Rights and Education Project, added that. And we've also been included on the Healthcare as a Human Right 2025 policy agenda, which has been a big thing that we really wanted, because we realized we can't do this alone. We've got to do it in concert with a lot of other organizations. So just high level review of the changes. We kind of reworded the opening statement and updated it and tried to incorporate our old 5335 along with the language from the Universal Healthcare Commission that created the Universal Healthcare Commission. We wanted to make sure that pre-existing conditions were added in there, just in case the Affordable Care Act is repealed. So we made sure that was in there. We changed the governing board to a citizen majority governance board, made a smoother and more definitive transition plan. And we actually had a hardship waiver in there for our businesses, but we realized when I read through it last time that it wasn't permanent. It was only for like the first 3 years or so. And we thought, why isn't it permanent? Because there could be many reasons why a small business or any business might need to get a hardship waiver of some sort. We updated and made a much more progressive financing mechanism, which we're really, really proud of. I don't know if you guys know it, but here in Washington, we have one of the most regressive tax systems in the country, which is why many billionaires love it here, And then we just kind of made a bunch of other improvements, so smaller ones. We made it a citizen majority governance board, kind of removed the legislators because we weren't seeing them really being effective on the Universal Healthcare Commission. So we added a lot of just citizen people onto that, along with people who are already involved with our healthcare system, like the Department of Health, the Healthcare Authority, and the Insurance Commissioner and such. So, and then we changed our financing model. So previously we had just an employer assessment of 10.5%, and 2% could be passed on to their employees, and that was based on their income. The employee's income. Then we had a 2% sole proprietor's tax. So anybody who is a sole proprietor would just pay 2% of their net profits. And then we had a capital gains tax. We've always had that in there. And initially, since we initially did our first initiative, our state already passed the capital gains. It was actually validated through the court systems. And so in that capital gains tax is for education. So we kind of changed ours around a little bit to include the education and a little bit more for healthcare. So what we did for the employer assessment is we made 3 graduated levels of the healthcare assessment. So there's the standard assessment remains at 10.5%. For someone who'd be considered a mini business, it drops down to 6.5%. For someone who is a micro business, it drops down to 4.5%. And then for all of those businesses, they can deduct 2% of that from the employee's payroll or paycheck. So, and then we still have the 2% sole proprietor tax, and then we made the changes to the capital gains tax. So this is kind of how, like, what it used to look like, but now we've changed it. So that's our old flyer. But what that looks like now is kind of in this category here. We always had a $15,000 exemption for the first $15,000 of every employee's pay. And we weren't sure how this was going to affect the funding stability of the trust. So we went ahead and removed that from the standard assessment just to make sure that, because we didn't really have the money to do another funding study, you know. But we left it there for our mini businesses and our micro businesses. So that's kind of how it breaks down. And then where they fit into there is determined by, it's like their net profits. It's not their net profits, it's their net revenue. So it's their revenue after they, the cost of whatever they're producing is taken out of that. It's a line item on their IRS tax form. So basically this is kind of how it looks like. So it's a little bit easier to visualize here, with the employer paying the darker colors and the employee is participating in the lighter colors. The green column is for the standard assessment, and then the blue is for the mini businesses, and the yellow is for the micro businesses. So, and then if you can see, that one kind of looks a little bit scary, but if you can imagine, that last column there is for people who have an income of $290,000 a year. We've always said that for the majority of people, they will pay less, but for some people, they will pay more. And actually, I think even at $290,000 a year, when I calculated it, it's about $500,000 a year that people will start to pay more. Plus, this system has no copays, no deductibles, covers all your prescriptions, covers hearing, vision, dental, all that too. So an example of what would that look like if an employer had, for every employee that they had that made $75,000 a year, the employer is going to pay on a standard size business $531 a month. The employee is going to pay $125 for a total of $656. The mini business, the employer would pay $225 a month. The employee would pay $100 a month for a total of $325. Whoops, sorry about that. And then for the mini one, you guys are in the way, I can't see it. I think I can remember. Okay, it's $125 that the employer would pay per month, $100 that the employee would pay per month, with a total of $225 a month. And I can't get it to move. Okay, here we go. And then the capital gains tax is a little bit, looks a little bit different, but basically what we currently have now is they don't pay anything on capital gains until they reach $250,000 a year in capital gains, and then they pay 7% to education. So what we did is we added from 200,000 to 250 an additional 5% that would go to the Washington Health Trust. And then that 7% would stay the same from 250 to 300,000. And then once they get up to 300,000, we would add an additional 2%. And the thing about that capital gains tax is that we never really needed it in our previous funding studies. We don't know currently. We kind of think we do need some additional funds, but we didn't need it before. So this was really to allow those people who only made money on capital gains to be able to participate in the trust. So, let's see if I can. Oh, sorry, not. And we really are trying to make this as a collaboration between the Hicker, that's their symbol, and our legislatures on both sides, the Senate and the House, and our current state, healthcare authority that, manages the commission, that manages our Department of Health, all that stuff right now, trying to make it not just our bill, but everybody's bill, right? Including everybody. So let me see, hang on. All right, I'm sorry, I'm having a hard time with this. All right, so now is the time. We believe that healthcare is a human right, and that means that universal healthcare needs to be a matter of policy for Washington State, and we believe that it is actually already. The Washington Health Trust fully articulates our shared values in the form of actual legislation. We need the Washington Health Trust to hold the Universal Healthcare Commission accountable to make actual progress. They've been working since like 2021, and we feel that they're not showing enough progress. So together, the legislature and all of our organizations working on these solutions in Washington can provide the desperately needed hope and a pathway to real healthcare justice and economic relief for our state's residents. And now that I added this, okay, that we are in uncharted waters and potentially losing our taxpayer dollars that currently support our multi-level healthcare system, this is my question to you guys and to my legislatures and to everybody that I'm asking now. What can we do emergently to take care of our residents now? And then how do we make those changes sustainable for the future, right? That's the question. So I'm open to questions or suggestions. I'll be writing them down.
Kathryn, have you gotten out into, it's Barbara Harrison from New York. Have you gotten out into diverse communities from rural to low income? And what have their feelings been about that? Because we can't count on the media to disperse information that's factual and that's going to be supportive of this.
Yeah, that was one of the main goals of our town hall is getting out into those smaller communities, those places with all of those hospitals and stuff. What the legislature I talked to this morning, she said, how are we going to present this to where we can sell it to people because that's the problem. People, how do we get them to buy into it and stuff? And I told her quite frankly, we don't have any problem selling it to the people, right? We have a problem selling it to our legislators. There's very few people that we have a problem convincing that this is the way that we should go.
So you found people receptive when you go into rural communities.
Definitely.
It's not what it appears to be when the media talks about, rural versus, I'll put progressive in quotes.
Right. And our question is, what do we do? What do we do with our rural hospitals? We have rural hospitals, even though the cuts aren't supposed to be happening at earliest 2026, are saying, we're not going to survive this. And they're going to shut their doors now. Take, and that's my underlying thing. Is this maybe a real estate deal? Are vultures going to go in and buy up all those hospitals cheap? And then rebuild them. And you know what? I don't know.
And it's always been problematic with the rural areas. I know. So this is across the country, this problem. And yeah, that's why we have got to get out and do the work. And in New York, I've had problems convincing, and I hate using that word, the progressives. Let's go out. We need to go in the rural areas. And storytelling is a wonderful way of bringing people together.
And that's actually what we did. The name of our town halls was Centering Our Stories. And we tried to draw people in to share their stories, into the conversation. If people have ideas, that's what our legislature asked us this morning, we said, the trust isn't designed to boom, go in place and, oh, we have universal health care. There's a transition. Can we do this more emergently? We actually, in the last iteration, one of my legislators told me that the transition's too fast. So we slowed it down. We made it take longer. But can we do it more rapidly? And the other thing too is, remember, this was originally designed based on our tax situation here in the state of Washington, and your state might be very different, have a very different tax base. So.
Oh, Hank has got his hand up from Maine. Hank.
The financing
Mhm.
it's good to see that your numbers are similar to other states and studies numbers. Have you ever had a question, or one of the hardest sells to is how much is it going to cost, and what is the actual price for each group? And I like how you've broken it out. Have you ever used other states' estimates over the last 5 to 10 years, which all look about that 8 to 10% range, the 3 to 5 to 8 to 10% range? Do you find it useful to say that the financing is consistent across the years and the studies? Is that something you do or something you find helpful?
Well, that's what our board chair says. I mean, we tried to see if we could find somebody else to do another funding study. And for just a very just a review of everything, not even a deep study, it's like, it was over another $10,000, which we've already paid like $25,000 as an organization for our 2 previous studies. So, and all of the other studies that have been done, they all show savings. So I've had a difficult time convincing my board to pay that. And actually, in all honesty, we don't really have that kind of money to dump into that again to prove what's already been proven multiple times over. I don't think that we have the time or the energy. We did, one of our focuses with the commission and with our legislatures or the healthcare chairs was to try to get the state to do that. They'll dump $500,000 into a study, at the drop of a hat. So we were hoping that they could do that, but they didn't want to do that.
Okay. Well, thanks, Kathryn, for that presentation. Any other questions before we move to Chuck and some important updates? One question that Warren George will always raise is that if you do tax the highest income above $500,000, that you'll scare physicians out of the state. Is the way you've designed this protecting you from that kind of thing?
I don't think we're worried about the physicians leaving. I think we feel like the physicians will stay. What is, okay, I've seen the contracts for my hospitalists, and they're only making like $250,000, $300,000 a year. They're still going to save money. Yeah, maybe the specialists, and the specialists don't like to hear that. The intent is for the specialists not to make so much money, and they might be making that more than that $500,000 a year. That's what I count. When I calculated, it looks to me like, from what my friends that are on the well-to-do side of what they're having to pay for their health insurance and such, that's kind of the breaking point. Because that $500,000 net profit, they're going to pay, I can't remember. Now I got
25,000 a year.
Yeah, it's like $2,000 a month. Yeah.
And an interjection in that sense, if Warren George, so my recent research in Nova Scotia and New Brunswick is it won't happen in the United States eventually, overnight, but the physicians are all LLCs. They all are independent. They're like dentists. They own their own practice. They run their own business. So their net income versus their gross is going to be something to work on. But if it's $25,000 for an individual, that's what you'd pay for a family plan on the market, but no deductibles, no copays, et cetera, et cetera. So that the marketing part of it was you're going to pay the same in the higher income, not the extreme income, but the higher income, and yet it'll be much simpler. And oh, by the way, physicians, you'll get paid every 2 weeks, and there's no DRGs, et cetera, et cetera, et cetera. So I think there's a way to market it to physicians as a way to other high income but not highest income individuals.
And what does that then do to bring down the income inequality gap? My question is, if we were to do something like this, where we're gonna tax, because that's when you put in, when we made our savings calculator, when you put in a company where there's billions of dollars and you've got someone making multi-million-dollar salaries, it doesn't save money. It doesn't save that company any money, but it does save most companies who are paying reasonable salaries to people. Okay, so what would that do to bring down the income inequality gap in America?
One more consideration that I'm channeling Warren again is that capital gains taxes are at their lowest when the money is needed most. And so I understand why you probably didn't include it in the first round.
Yeah, that's what I'm talking to our legislators about. What can we replace that with, something that's more stable, like a wealth tax or an excess compensation tax? I really like that idea. I don't feel comfortable and the other thing too, in this situation now, do we need to put the premium? We used to have a premium where we had a 4-legged stool, and then it was a 3-legged stool. And is it that stable with only 2 legs? I don't think so. I think we need to add something that's more stable. And you're right, if there's no capital gains, there's no income from the capital gains. So if the economy crashes, there's no capital gains. And so they still don't get to participate.